May I invite Dr. Padmasree KM for the next talk, Considerations in Spectacle Prescription and its Use. Over to you, Padma.
Thank you, madam. So now we are on to the management of squint. My topic is spectacle considerations in squint. For a squint case, we have many. Before surgery, we will have to manage them with several non-surgical modalities. I will be stressing upon the optical management and the treatment of amblyopia. How does the optical correction help? It gives us sharp, well-focused retinal image which will help in functional control and also the development of BSV. It also corrects and maintains the relation between accommodation and convergence. So for optical correction, refraction is our first step. Pediatric refraction, as you know, is challenging because of the strong accommodational tone in children. And the eye growth demands repeated refractions also. So the gold standard is a good retinoscopy. If you are using an auto-refraction in school-going children, you should combine it with appropriate cycloplegia. So for our dark iris and small children, it is atropine 1% eye ointment. So to fully relax the accommodation, we have to go for no shortcuts. So atropine 1% ointment, rice green size, twice or thrice daily, for 3 consecutive days preceding the day of refraction should be used. And if you see that in older children, if you have residual variable angle seen after milder cycloplegics, you have to go for an atropine refraction. When they come for retinoscopy, see that the relaxation of accommodation is there. So by doing a dynamic retinoscopy. So our step 2 is a proper prescription. Based on the retinoscopy, you have to fully correct the refractive error in presence of squint. That means only the distance correction need be reduced from the retinoscopy value. And you can prescribe for a preschool children without waiting for post-cycloplegic acceptance. So children in their metropization phase, they will have a lot of refractive errors revealed during the retinoscopy, but you need not prescribe all. We have to go, we can go according to the guidelines given by American Academy of Ophthalmology. I would like to highlight hyperopia with esotropia. The correction, threshold is as low as even we have to prescribe 1 point diopters of refractive error. And one more thing that I would highlight is that threshold for correction in anisometropias should be very lower if the child has strabismus. This national consensus statement for our population also confirms the same. So after your prescription, if it is properly fitted in the child, fitter for the child will comfortably wear it. We have to look at the size of the spectacle, which should be big enough to cover eyes in all position of gaze, and the nasal bridge should be broad and comfortable to the child. Ear supports should be comfortable, and that makes sure that the spectacle does not fall forwards and fit in place. The article also gives the recommendation for type of spectacles. They should be lightweight and break resistant. The child should not peek from the sides of the glasses. You can even prescribe for a 3-month-old child. Regular 6 follow-ups for vision and retinoscopy is a must. Coming to exotropia and refractive errors. Myopia is the commonest refractive error associated with exotropia, as you know, because of the poor accommodation. So correct myopia according to the guidelines, because once you correct it, the spectacle stimulates accommodation, it will improve convergence and control of intermittent exotropia. So can we give overcorrections to myopia to control exotropia? But that is questionable. And you can see hypermetropes with exotropia. Why? Because in high hypermetropia, they cannot accommodate to clear the blur for distance. So they can go for exotropia. Moderate hypermetropia also, if you give glasses, that will take away the accommodative effort. So appropriate undercorrections can improve control of exotropia in hypermetropes. Astigmatism, you have to fully correct it in children. Here, this child had -4 diopter cylinder of astigmatism. She has a large angle exotropia for distance and near, and giving her spectacles has improved her near vision control over exotropia. So, an exotropia can be any refractive error. So, you have to find out from retinoscopy and manage accordingly. Coming to esotropia and refractive errors, accommodative esotropia, the effort of accommodation is the culprit. And we have the refractive type and hyperaccommodative type. The refractive type, the hyperopia amounting to +2 to +6 diopters may be there, and once you give the correction, you can see that the eyes are straight with the spectacle. So here it is important that you go for a constant wear spectacle correction, and you have to educate the parents that spectacles are only controlling the strabismus, not curing it, so the child has to wear it constantly. Coming to esotropia with high AC by A ratio, here they have abnormal relationship between the accommodation and accommodative convergence. So for near, the esotropia will be larger, and that can be made straight by relaxing the accommodation with a +3 add. Because of time shortage, I am not talking about how to calculate the AC by A ratio. Anyway, if when the child is given a spectacle correction, it should be an executive type of bifocal and the flap top style segment, and the top of the segment should be crossing the pupil. So that makes sure that the child uses the spectacle for all near activities. Step 3 is our amblyopia treatment. The abnormal binocular interaction in strabismus disrupts BSV development and will suppress the deviated eye. So there will be diminution of vision in that eye. That is, you have to, that is amblyopia, and you have to treat amblyopia whenever it is present. So a reliable baseline visual function should be assessed, and the gold standard treatment for amblyopia is correction of refractive error and occlusion of the better eye. It can be given as direct skin patches or as spectacle occluders. Full-time occlusion is total occlusion of the dominant eye alternated with occlusion of the amblyopic eye. The frequency of the patching depends upon the age of the patient. Example, if the child is 2-year-old, it is 2:1. That is 2 days of dominant eye followed by 1 day of amblyopic eye. This kind of occlusion has got the risk of occlusion amblyopia, so you have to carefully follow up. So the amblyopia treatment studies by the Pediatric Eye Disease Investigation Group has tried part-time occlusions. Many trials have been there, and they have found out that in severe and moderate amblyopias, you can even do effective patching with 6 hours or 2 hours. The most important thing is that you have to initiate the treatment as early as possible. So part-time occlusion is better accepted in school-going children, but that hours of patching should be given in a single stretch of time. Spectacles can also be used for prism therapy, but it is not a favored treatment, but it can relieve diplopia in conditions like residual deviations and consecutive deviations. So my take-home message in squint management prior to surgery is that the quality of your non-surgical management reflects the outcome of the surgery. So do all these steps properly. Refraction with proper cycloplegia, prescription whenever there is significant refractive error is there, and give a well-fitting spectacle to see a happy child coming back to you. Detect amblyopia whenever it is there and treat it and do a proper follow-up. These are my references, and thank you for your hearing.
Thank you, Fatma, for that elaborate and excellent talk on prescription, spectacle prescription.